Good morning, everyone. I'm Brad Stotts. I'm the Faculty Director for the Center for the Business of Health, and I'm excited to welcome you to our session today on healthcare in 2021 under the Biden administration. The Center for the Business of Health was established as a multidisciplinary initiative bringing together expertise from across UNC to further thought leadership on critical business issues impacting healthcare and to prepare business leaders throughout the ecosystem. I'd like to thank both Blue Cross Blue Shield of North Carolina and the Duke Margolis Center for Health Policy for co-hosting today's session with us. We're incredibly excited about our three 30-minute panels, each session with an individual from Duke, from UNC, and Blue Cross Blue Shield of North Carolina. Wonderful partnership to help us better understand healthcare. We'll begin the discussion together. I'll be moderating the three panels, and please share your questions through the Q&A functionality within Zoom. We'll make sure to incorporate those, especially in the last 5 to 10 minutes, but we may weave them throughout depending on what comes in. We're going to kick off with our first panel around defining the value of health. And so this panel is going to discuss value-based care, both in the state of North Carolina and beyond, with a particular focus on social determinants or drivers of health. We have three fantastic panelists. We have Dr. Sierra Zachary. She's an assistant professor of health policy management here at UNC Gillings. We have Dr. John Lumpkin. He's a vice president of Drivers of Health Strategy, as well as president of the Blue Cross Blue Shield of North Carolina Foundation. And finally, we have Dr. Rob Saunders, research director of payment and delivery reform at the Duke Margolis Center. So thank all three of you for being with us this morning.
Thank you.
Absolutely. So maybe to kick us off, Rob, could you give us a bit of an overview, your perspective on where we stand in the transition to value-based care from fee-for-service in North Carolina and the U.S., and then also maybe a little bit about why social determinants of health are such a key part of this discussion?
Absolutely, thanks. And just to give the quick summary of where we are right now. So for about the last decade, there's been a massive push nationwide to shift from the traditional fee-for-service payment models to more value-based models. And we're about, in the most recent surveys, 35 or 40% of all healthcare dollars now flow through one of these types of value-based models. North Carolina is really at the vanguard of all of this. And depending on how you calculate the numbers, we're probably shifting to about 65% or likely even higher percent of our dollars to move through some of these value-based contracts, thanks to the Medicaid Transformation efforts going by statewide, which will move a lot of our Medicaid payments into these types of value-based models. And Blue Cross Blue Shield of North Carolina has taken a very active leadership role with their Blue Premier and now the Accelerate to Value program that have really also started to provide new options for value-based models. There's bigger reasons why we want to incorporate these types of value-based payment models in order to provide more flexibility to providers, to provide the right incentives to encourage high-value care. But I think, especially in these COVID times, a big reason is to provide more financial flexibility and resilience for providers. Those providers who were only receiving fee-for-service payments were hit really hard when the lockdowns happened. And, we saw furloughs, even practice closures. And so if there were some types of value-based payment models around, say like some type of shared savings or maybe even a broader global payment, those practices did a lot better. So that's a big reason. How does this relate to social determinants of health? Well, a big part of that is that these value-based payment models allow for more flexibility, depending on how they're structured. And that then allows the providers to not only provide just direct medical services, but think about which of those social drivers of health are a challenge for their population and provide services that help them, that population be able to account for those factors. So that's the big picture. Let me stop there because I know we're kicking things off and continue the conversation.
Awesome. Thanks, Rob. And kind of throughout, I know we have some questions to go through, but also, important to have a discussion here. So our panelists may jump in with questions for each other too. You're kind of fully invested with that power. But kind of to stay on the theme, Sarah, maybe you could talk a little bit about kind of North Carolina. I know you were a part of the North Carolina Institute of Medicine, Healthy North Carolina 2030 Task Force. And as a part of that, how did you all think about the impact of social determinants of health in North Carolina?
Yeah, first, I just want to say thank you for having me. I'm excited to talk about this topic. I think much of my work has been focused a lot on consumer advocacy, making sure that people get all the services that they need. So thinking about these social drivers has been so important to a lot of the work that I've done and some of the research. And thinking about North Carolina in particular and some of the work at the North Carolina Institute of Medicine, there was a specific work group that looked at social and economic factors that influence health. So thinking about, incarceration rates, children's, third grade reading, thinking about unemployment, and the, folks who are living below the poverty line as well. So I think, when we met together, realizing that a lot of the health outcomes, a lot of the disparities that we see and inequities for many North Carolinians, we understand that there are issues around, income and education and housing. And I think Rob was mentioning, the Medicaid transformation. And I think that has really, presented a good opportunity for bigger conversation with different entities like NCIOM to include that in their Healthy People 2030 report. And there was also another task force on accountable care communities that was really important as well, which took the lead from our Medicaid transformation efforts in this state in thinking about what are these social services, what are these drivers of health that people need in order to support their ability to, let's say, follow the doctor's orders once they are, released from the hospital or after they meet with their primary care provider. So I think, recognizing that there are, issues outside of like health coverage and, are you taking your proper dose of medication is a really important state. It's really great to see North Carolina kind of leading these efforts, both with Medicaid, with the Healthy Opportunities pilot, but also seeing the leadership from NCIOM with both of these task force in the reports that were given that place much emphasis on social drivers of health. So I will stop there to give opportunity for more questions or interaction.
Yep. Perfect. Thanks, Sarah. Before I want to turn John to you with a question, but Rob, a question from the audience asking to define value-based care in layman's terms. You want to take that one?
I'd be happy to. I'll take a first stab, and I hope my co-panelists can jump in here as well. So in terms of value-based care, there's a lot of different types of value-based care, and we can get incredibly technical very fast. But if we stay high level, there's probably two common characteristics for all value-based care programs. One is some level of accountability. So in a more traditional payment system, you get paid no matter what. You do a knee replacement, you get the payment for a knee replacement. In a value-based care model, there's some accountability for a measure that may look at infection rates or ability to return to work after that knee replacement. So there's an accountability piece. And then there's often, second, some type of change in the way that we pay for healthcare. Maybe instead of for that knee replacement, we pay separately for the surgeon who's actually doing the knee replacement procedure. We pay separately for the implant. We pay separately for the post-acute care rehabilitation. In a value-based care model, we wouldn't pay separately for all those things. Maybe we would pay all of those together in what's called a bundle payment. So I think those are the two factors that really differentiate value-based care, that accountability, and then the way that we change payment, that together hopefully will help change the way we provide care by giving more flexibility and by encouraging more of a focus on value instead of just providing more care.
Fantastic. So John, I want to go to you, and certainly if you want to add anything to Rob's answer, great. If not, that's good. But I'd love for you to talk a little bit about what you're doing at Blue Cross Blue Shield in North Carolina as you focus on kind of drivers of health.
Well, they're all interconnected, because as we look at value-based care, and a critical component of that are the outcomes and the sharing that occurs between the insurance company and the healthcare systems and the healthcare providers. When we save costs and have better outcomes, everyone shares in that benefit. But if you don't achieve those goals, everyone shares in the losses. And what that means is it changes the incentives. So for a clinician, it's no longer good enough just to write a prescription for insulin for someone who has diabetes. Now it's important for them to think about, well, where does this person with diabetes get access to healthy food? How do they get transportation to go to the pharmacy to get their medications? Where do they have a safe place to exercise? These are all the conditions that exist outside of the clinical setting that are called social determinants of health, or we call here in North Carolina, the drivers of health. And our approach at Blue Cross is to look at it in a number of ways. First is that, like many other health plans, we're applying some of the federally allowable changes into Medicare Advantage and other programs. But we also think that there's a fundamental gap that exists in that most of the studies say that if you have food insecurity, hunger, lack of access to food, that you have increased medical costs. There's very poor evidence to suggest what you can do to change that. And so we're taking a very rigorous and methodical approach to not only implementing changes, but then to measure those changes to create the evidence so that we can understand what the proper dose and duration is. So some of the benefits might be a food benefit after hospital discharge for 2 to 4 weeks. That's an allowable benefit. But people who are food insecure are food insecure all the time. So if we're looking for interventions, we want to understand what the appropriate dose and duration of those interventions. Now, the most commonly reported social need that results from communities having community drivers of health needs is food. And this is a good example of some of the things that we're doing. We're having a program where we're identifying members who are who are eligible for SNAP, Supplemental Nutrition Assistance Program, and we're giving them assistance in signing up. We've also got another program where we're delivering food boxes that meet the needs of particularly people with diabetes and hypertension who are food insecure. Also providing a produce supplement, working with reinvestment partners based in Durham to provide a card that's good at Food Line for $40 a month that's only good for produce and fresh vegetables and food. And then finally, we are tying those in with nutritional coaching. All the time, we're measuring closely the impact upon outcomes and the impact upon medical costs to make the case that this is an important way to not only have better outcomes and better treat people, but also improve the ability to lower premiums, which is a pressure on people with low incomes.
So John, kind of two questions that have come in that I'm going to kind of combine together of how do you think about drivers of health in a way where value might mean bad for business, kind of this person asking less sick people means less business, or also the challenge of time that maybe the benefit doesn't accrue for kind of months or years, and yet as a payer, kind of you have to think about the moment right now. How do you balance those tensions?
Well, the interesting thing, Blue Cross Blue Shield is not a public company. We don't have to provide profits to our shareholders. We are beholden to our board, to our mission, which is to improve the health and well-being of our members and community. So for us, one of our goals is to reduce our premiums so that they're affordable. And you can only do that by reducing costs and reducing utilization and by, in fact, achieving health. Now, the second important component of this is tying it into, people. 1 out of 3 people in North Carolina is a member of Blue Cross. And we recognize that people who live in communities may be our members today, but there are other people in that community who may be our members tomorrow. So if we don't address those factors in the communities, we're not actually, in fact, having that impact of moving towards better health. And what we've been doing in some of our early analysis, we can see a difference. People who join Blue Cross, who live in a food desert, have higher healthcare costs. So there is an incentive for us as a company to do the right thing to improve the health and well-being of our members and the communities where they live.
I'm curious, Rob, Sarah, any comments on that broader picture as you kind of have seen things, of these differences in time and kind of differences in benefits?
Yeah, and maybe I'll start. So I think there's what this is highlighting is really a big challenge in terms of where should the healthcare system be involved. So for instance, we've got a very established social services and community-based organization infrastructure that's been built over multiple decades. What we don't want is to have the healthcare system come in and either try to create a parallel system to that, or worse, try to have a competing system. So I think one of the big questions here is, value-based care gives us an opportunity to start to address social drivers of health. It probably means that the healthcare system shouldn't take on all social drivers of health because it's not in the right place to do it. And again, there's already an existing social services and community-based organization infrastructure out there that may be, in fact, in a much better place to do it if they had proper funding. So I think that's one of the key operational questions that we've seen and gets to this question, are there specific interventions where the healthcare system would be effective, they're well-placed, they probably should still be partnering with social services and community-based organizations, but they can lead to an impact in a relatively short amount of time that can lead to those types of improvements that everyone can see.
Great. Sarah?
Yeah, and not to sound like a broken record, but this is why I think like this Healthy Opportunities pilot with our Medicaid transformation is going to be so helpful in informing these models as well, because they are going to have payers partner with community-based organizations that have been providing these social services that understand their community's needs and can, give that funding and support. So I think, hopefully soon we will be getting data and hearing maybe even anecdotal evidence of what works, what doesn't work, so that we don't have that tension between developing or, encouraging value-based care, but disrupting what's already there, what the community has already built and knows what they need.
Great. Thanks, all three of you. John, obviously we're in the middle of a global pandemic. As you look at COVID, kind of how is it magnifying some of these challenges with drivers of health or social determinants of health?
Well, I think we've all seen the dramatic impact of COVID, particularly on communities of color, which have had an impact, and also on rural communities across North Carolina and across the country. They've highlighted the fact that people who live in communities that have been historically disinvested are also those who are most at risk. And let me just sort of put that into context, because as James Baldwin said, not everything that is faced can be changed, but nothing can be changed unless it's faced. And the issue that has to be faced is the impact upon race in our society. There have been studies that clearly indicate that people who are exposed to discrimination on a regular basis are more likely to have high blood pressure, to be obese, to have metabolic syndrome, which is a precursor to diabetes, to have heart disease, lung disease, and kidney disease. All of these are risk factors for severe and deadly outcomes for COVID. Chronic disinvestment in communities, which has occurred based upon public and private policy, from redlining to looking at some of the rural communities in North Carolina, in the counties that are the poorest in Eastern North Carolina, are the same counties that at the end of the Civil War had the highest percentage of enslaved people. And then they have been subsequently continued disinvestment. That means poor access to healthy food. That means poor access to transportation and transportation deserts, difficulty finding jobs, inability to accumulate wealth. All of these factors now, we're seeing them to come together in creating increased risk for COVID. So as we think about how we get ourselves out of the hole that we have dug, and COVID has highlighted the impacts, we have to think about not only looking at food, which has been incredibly a problem, access to transportation and other social needs, but we also have to address the impact of decades and centuries of racial policies that have led to these outcomes.
Rob, Terry, other thoughts on COVID and its impact?
Yeah, thank you, John, for raising that. I do think that's really important to recognize how COVID is, lifted up more institutional and historical factors that have left us with these inequities and disparities. I was just going to also add, considering a driver that we've been talking about, like in housing, I read a report recently that's saying that if we would have had a moratoria on evictions just in the month of December, we could have prevented, nearly 160,000 deaths related to COVID. So I think people are seeing these connections of where you work and where you live and where you learn does impact your trajectory and the comorbidities and mortality with COVID. So I think we are seeing more of this value and these wraparound social services that can hopefully improve outcomes.
And Sierra, maybe a follow-up question from the audience. It's asking about kind of the role of public health, and I think we touched a little bit on this already. But kind of how do you think about this with the work you've done, that we don't try to use a medical model to fix public health and societal issues?
Yeah, I think a little selfishly, being a public health professional, it's like, oh, finally, this field is getting some recognition of the years of underfunding. We are, seeing that, and I'm hoping that in addition to inspiring more people to enter the field, that we will have, key stakeholders and lawmakers who want to reinvest in our public health system, and seeing how the public health and the clinical side of things, they really do work together. And what we're seeing with social, determinants of health, these new models of care, that they're not siloed, that they really are together and improving health outcomes for all people, especially our historically disenfranchised and marginalized groups.
Yeah, certainly. I think the theme of partnership is coming up repeatedly and importantly as we look at these different elements. I do want to think about the change of the administration. And so, Rob, why don't we start with you, although I'd love to hear from each of you. How do you see kind of the Biden administration approaching things maybe differently?
And I think, if we look at where the Biden administration has publicly stated their priorities, number one has been COVID. And as Dr. Lumpkin said, COVID has really laid bare a lot of these inequities, which are many times driven by social determinants of health. Another, though, key stated priority across the health portfolio from the Biden administration has also been equity. And so I think with that said, there's going to be an increased attention on where there are opportunities to improve equity, and where there's opportunities to improve social determinants of health. There's a few ways we might see that play out, and I suspect the next panel will get into some of that as well. One question is, are there additional opportunities for Medicaid flexibility? So, for those who are health policy geeks, what's called the Medicaid waivers. Basically, are there opportunities where other states could do what North Carolina is trying to do through its Healthy Opportunities pilot? As Dr. Lumpkin noted, there's already some work in the Medicare Advantage program in terms of covering these supplemental benefits that often address social determinants of health. And there's other non-Medicare, non-Medicaid avenues, like investments in our community health centers or rural health centers, mental health centers, increasing community health workers. So I think those are probably going to be some of the actions that the administration is going to explore and going to be able to think about in terms of improving social determinants of health, and hopefully will be helping them meet their broader goals of equity, improving equity, and addressing the COVID pandemic.
Great, thanks, Rob. Maybe John?
Sure. So, I think we're looking forward to see what the new administration is doing, and they certainly have made a lot of steps forward in trying to address the pandemic. But we think that there are certain important things that need to occur. And so we're looking to those kinds of things. Things such as trying to change the calculus that has gotten in the way of North Carolina adopting expansion of Medicaid. Things such as removing some of the barriers to integration of healthcare and drivers of health nonprofits. Things for payers like us of adjusting how they determine the medical loss ratio, which seems like a very arcane calculation, but it says basically if we can't be allowed to expend money to cover these non-clinical drivers of health, then it makes it difficult for us to pay for it. There's issues related to privacy and security, where nonprofits have to meet all the requirements of HIPAA in order to be able to get referrals from healthcare. We need to solve that problem so that these nonprofits can actively participate. We don't want to supplant them with for-profit entities because these are based in the community and belong there. And we need to improve the ability to test and innovate in Medicare and Medicaid. Because of some of the restrictions, payers can't do pilot programs, can't look at different ways of providing these services, all of which we think and hope that the Biden administration will be more open to.
Great, thanks. Sarah?
Yeah, I'm really excited for tomorrow. It's supposed to be Healthcare Day in the Biden-Harris administration. So we've already seen that, planning on extending or reopening enrollment period for the marketplace, which is a part of the Affordable Care Act. We're hearing of, removing some of those barriers that were, created or accepted in the previous administration, such as work requirements for Medicaid. So I think tomorrow will give us a lot of insight. I think, also just thinking about the executive orders that have already been, signed, even on environmental, factors, just rejoining, the World Health Organization and the Paris Climate Agreement. So I think a lot of, we're seeing action already that is thinking about some of these other linkages that impact these social drivers of health as well. So yeah, I think as being a policy advocate, I think people in different states are maybe relieved and excited to see what opportunities to, one, strengthen the Affordable Care Act and the different aspects of that, but also our Medicaid and Medicare programs as well.
Thanks. So John, a couple questions around kind of employer-sponsored group health plans. One sort of asking in general on value-based care, how they share in this, but another saying, how can they help with identification of members who might need some of these services? And so maybe you could talk a little bit about how you're partnering with employers on that front.
So what we're finding is that actually the kinds of programs that we're putting in place, we have more flexibility working with our employer partners than we do with the federal government. So as we're thinking about a food delivery program, as we're thinking about access to produce through a card program, we're actually doing that with our commercial members. So we think that there is a lot of room for partnership. The interest is the same. They want to have better outcomes for their employees. They want to have lower costs for their premiums. And that's exactly what we want to do as an organization.
Great. Well, I know we're coming up on the end of our time together, and so I want to give each of you a chance to maybe offer kind of a concluding thought about where we're headed. So maybe Rob, you're first on my screen. We can go Rob, and then John, and then Sierra to close us down, if that's okay.
Thanks, Brad. So I'd say just one quick thought is that the policy world right now is very supportive of this broader push toward equity and broader push toward social terms of health. I think the big challenge and what we should look for next is implementation. And this is actually can be very tricky to do in terms of developing, say, those partnerships between healthcare and community-based organizations, or North Carolina has our NC Care 360 platform, but having data that transmits between healthcare and community-based organizations and back again. And so the big focus probably in the coming months and the coming year will be how do we actually do this in a way that is effective and helps improve people's lives.
Great, thanks, Rob. John?
Yeah, I think it's really important to note that addressing these drivers' health are critical. And some people argue that the cost to do them is high. We think that the cost of not doing them is even higher. People who are food insecure are more than twice as likely to report ER visits, more likely to be admitted to the hospital. If we don't begin to address this now, we will continue to see healthcare costs spiral out of control.
Great, thanks. Sarah?
And I would just say from a community consumer perspective, I've also been really encouraged about, North Carolina, the state, and other organizations really wanting community member feedback and input. I think that is also really critical in how we address these drivers of health and how we break down these silos for how things are implemented so that we can improve health outcomes for everyone.
Great. Thank you, Sarah. Thank you, John. Thank you, Rob. Thank you, Sarah. Really appreciate you joining us today to talk about how health is being redefined with this focus on drivers of health. So with that, we'll shift to our second session of the day, talking about the changing notions of behavioral health and the impact on well-being.
Thank you for having me.
Thank you.
Wait just a tiny bit while we transition from one to the next.
Hi, this is Dr. Meltzer-Brody. I'm not able to start my video.
Okay, we should be able to solve that problem on the back end for you. Oh, perfect. Ask and you shall receive.
Brilliant.
Perfect. Looks like we are all here. So I will go ahead and kick us off for today. So very excited for our second panel. In this session, we'll explore the role of behavioral and mental health in our quest for well-being. We have three distinguished panelists joining us again. We have Dr. Samantha Meltzer-Brody. She's a distinguished professor and chair, as well as director of the UNC Center for Women's Mood Disorder. We have Dr. Roberta Kapp joining us from Blue Cross. She's the Vice President of Clinical Operations and Innovations. And then we have Haiti Torson, MPH JD, joining us as a Senior Policy Fellow at Duke Margolis. So thank you all three for being with us today. Dr. Kapp seems to be kind of coming on and off, but I think for the sake of progress, we'll press on with us, and I'm sure she'll be joining us here momentarily. So would love to kind of start the discussion thinking about kind of why is it so important for establishing this focus of behavioral and mental health as we think about well-being. So maybe Dr. Meltzer-Brody, you could start off with that one.
Yes, I'd be delighted to. So I think that the pandemic has really exacerbated so many issues related to mental health, and we are seeing a veritable mental health tsunami raining down on us. And so our challenge is, how do we address this as expeditiously as possible? Our referrals are through the roof. What has been a silver lining is our ability to deliver virtual care. And that's really been quite brilliant, amazingly adopted. We are incredibly grateful that the payers began to pay for virtual care, and telepsychiatry is particularly well suited. We now have almost a year of this transformation and a cohort study of how it's been delivered population-wise, which has been a remarkable success. And I would say that the only thing that allows me to sleep at night is knowing that the only way we can meet this mental health tsunami, with the prevalence of depression, anxiety by CDC reports up fourfold, the crisis in our children and adolescents being absolutely devastating, the crisis in other vulnerable populations broadly, and the fact that we have a shortage of mental health providers in any place other than more metro areas or urban areas, and that in rural areas like North Carolina, if you don't live near a population center, there's a dearth of mental health treatment, that having the payers continue to pay for virtual care and our ability to continue to expand this is the path forward to address this crisis.
Great, and thanks. Haley, do you want to start with that question too?
Sure. And before my time here at Chief Margolis, I worked at the National Governors Association for 6 years, where I worked with governors and their staff across the country. And we had a real focus on behavioral health and mental health. And I think with respect to physical health and behavioral health and mental health, there just hasn't been the connection made that needs to be made. And really, if you want whole person care and you want someone to be healthy and be able to, do well in their job and be able to, maintain housing and support their family, you really have to look at both sides of the equation. I think with respect to COVID, I think we've seen all of the challenges that we saw beforehand where, we did a project where who was the highest spend in Medicaid? And it was folks, that had behavioral health challenges that were left unmet. And that's why they were homeless. That's why they were going to the ER over and over again. And that's where the system was spending money, but not really making them better, right? So, I think there really needs to be focused at a national level, as well as, in North Carolina, of how do we really address that. Just wanted to throw out a couple of stats with respect to like what's happened with COVID-19. This is true across the country, but just in North Carolina. So North Carolina had a 19% decrease in overall emergency department visits through August, but they saw a 24% increase in opioid overdose deaths. And I think that is really reflective of people unable to access the care that they need. And we're seeing that across the country, talking to a lot of different state leaders about we really need to reinvest in addressing opioid use disorder. We are seeing the deaths rise. It's really alarming. I think we can talk later about what the Biden-Harris administration really wants to do on this. Another thing, Dr. Brody referenced the increase in mental health needs. So in North Carolina, there's been a threefold increase in reported symptoms of depression and or anxiety across the state. 1 in 3, up from 1 in 9 in 2019. So you just see, I think, unemployment, isolation, stressors from the pandemic has just really aggravated what was already a challenging situation. We also saw that on average for state psychiatric hospitals, admission delays for people who were referred from ED departments increased from an average of 145 hours in 2020 to an average of 185 hours in the first quarter of 21. So you see that again, there's been these challenges. And then I'll just say lastly, in the last decade, there's been a 91% increase in the use of involuntary commitment in North Carolina. So all of these stats, I think, just show the need for really focused attention on improving access to behavioral health services, which would include both mental health and substance use disorder.
Great, thank you. Dr. Meltzer-Brody, you mentioned kind of telepsychiatry, telehealth as a way to address this, and I think it ties to kind of what Haley was just talking about around access. Can you talk a little bit about kind of what has been holding it back and how you think about moving forward?
Well, I think the biggest obstacle to delivery of virtual care and telepsychiatry was that up until the pandemic hit in March of 2020, the payers did not reimburse for care. And that, frankly, was a deal breaker for trying to figure out how to finance that. So there's some examples of having external financing that occurred, but that really was a no-go in allowing it to be broadly adopted. Most of us will say that we did about 5 years of work in 2 weeks in March 2020 to pivot to this with varying degrees of success based on the type of medicine you practice. But in behavioral health specifically, it has been a godsend and it's been wildly successful. And I think there's just now we have almost a year of data to support that. Our patients like it, the providers like it. Now, does everyone only want to do virtual care? No. And certainly for people that want in-person care, there are certain populations for which it's preferable, particularly severe persistent mental illness, psychotic disorders, small children, people that have difficulty doing this. However, to address the population-based behavioral health needs, as we've heard described, Virtual care is amazing. It gets around the social determinants of health that become barriers. So it gets around the transportation issues because of lack of funding, lack of ability, lack of childcare. For a lot of people, they don't have money to drive. They don't have a car. They don't want to take 2 buses and a train. They're not able to take off work. It's simply not possible. And so if it can enable people to have a behavioral health or mental health appointment from the couch in their house or from their car or on their lunch break while sitting in, the parking lot somewhere, it's transformative. And that also gets around barriers of, I now need to travel and take off like a half a day or a day of work to go get treatment for my substance use or addiction or depression or things that are seen as very stigmatizing. And if you can do it discreetly, you can break down so many barriers. So I see the path forward. We have to continue to have virtual behavioral health care reimbursed by the payers at parity. And I do say at parity because if there is a significant disincentive for people to do it because you get some tiny percentage compared to in-person, it will be devastating. We need to then continue to understand how best to deliver it as we look closely at social determinants of health. But as we now have front and center the devastating impact of the pandemic, the health disparities at play, we need to be working extremely diligently and deliberately on how we're going to increase access to our communities that have been hit hardest. How are we going to make sure that rural areas have broadband internet access so that you then remove yet one more barrier to, you can say, well, virtual care is great. Well, sure, if you have actually internet access. But we have horrible trauma that has played out on both sort of the population at large, but in particular, minority populations who have been devastated by the pandemic, devastated by socio-political issues, and then many other groups. So I think this is such a unique time with enormous challenges, but also enormous opportunities. And I do think if we work together, we can move the bar forward in really, really powerful ways so that I've almost doubled my volume of outpatient psychiatry. There's a zero no-show rate. People, all of that was such a barrier is gone. People are able to get around stigma, get around barriers. And as we increase education and go after vulnerable communities, I think we can just do profound good that will have so many important downstream positive impact. For our kids, really trying to intervene now, which will change the trajectory of the next generation. If we don't get that right, it's going to be terrible.
Thank you, Dr. Meltzer-Brody. Dr. Tapp, great to see you. My apologies for the technical challenges. Would love to kind of turn to you to share a little bit about how kind of you at Blue Cross Blue Shield in North Carolina are thinking about kind of the role of behavioral and mental health and well-being.
Thank you, and sorry for the technical challenges. I appreciate your staff being very quick to help. So thanks for having me first and foremost. And so the way we have been thinking about it is, as you know, integration of behavioral health and physical health is key in overall whole person care and well-being. So working with the primary care providers and the behavioral health providers to really promote that integration. And as you know, we have partnered with Quartet to provide a technical platform to be able to help members get to that first appointment within 7 days as soon as they get that first diagnosis, and they have a confirmation of that appointment within the first 2 days. And so really embracing that and that well-being and whole person care is really a focus for us.
That's great. Thank you. I guess maybe to go to Haney to think a little bit about kind of this change, to start with the change in the administration and how you see that impacting the discussion that we've had so far.
No, great question. Sorry.
So a couple of things just to comment, just to focus on North Carolina and then talk about the new administration and the opportunities. So North Carolina, I think to Dr. Meltzer-Brody's point, telehealth has been an incredible motivating force to get people access to services, but it also has left some people out. Really, the telehealth services has been primarily in urban areas. So the rural areas in North Carolina, those folks are not accessing them for different reasons. Some is because of broadband challenges, But there's also the uninsured, and there's 1.2 million uninsured in North Carolina. That's a lot of people, and a vast majority of those are lower income. So I think a question for North Carolina, as well as other states across the country, is how do you think about addressing the coverage piece as well as the access piece? Because coverage is your means to be able to get to all of the things that we're talking about today in respect to services. So I think that's a question for North Carolina. With respect to the new administration coming in, we've seen a lot of interest. The Biden-Harris administration has put out a plan to end the opioid epidemic. There's a lot of money built in to fund state and local community organizations to partner with them to end the opioid epidemic through flexible grants. They want to have billions of dollars to expand medical residencies and access to education and training for medical personnel and substance use disorder diagnosis and treatment. They want to support training for primary care providers and other members of the health team to improve integration of care. They're very focused on veterans. They want to invest in veteran mental health issues. They want to accelerate integration of mental health and substance use disorder. And they want to do things like, invest in community health centers and mental community health centers to actually help with the network piece. I think, it's exciting to see all of the different ideas that are coming forward. I think the question is going to be, are they going to be able to get the funding and the resources and the infrastructure in place to get to the states and to the local communities, and how quickly will they be able to do that? So I think there's a question there. I think they also want to encourage coverage for states in different ways. And, we'll see how that plays out in North Carolina, but I think there's an interest in making sure there's going to be better access to the marketplaces. We heard on the last panel about opening enrollment and making sure people have access to that source of coverage. I think they'll be interested in identifying creative ways to think about Medicaid expansion or limited Medicaid expansion. And I know in North Carolina, through my work with the North Carolina Council on Healthcare Coverage, there's a real sincere interest across a lot of different groups to think about behavioral health and how to expand coverage for behavioral health and really getting to those folks that we know don't have services right now. So.
Great, thanks. Dr. Kapp, do you want to reflect a little bit on how you think the administration may change what we're doing on this front?
Sure, no, I agree with the prior speaker and many of the things that she mentioned. And, I would just say we're eager to work with the legislators and the regulators as this field evolves, and work closely with the providers as well as rethink through alternative payment models and how to improve access for our members and how to provide care to the conditions that we're seeing a rise and spike because of COVID-19.
Great. So Dr. Meltzer-Brody, a question from the audience asking that do you find carriers that capitate kind of mental health benefits, are they more restrictive with providing access through telehealth? Do you see any differences kind of as a result of that?
Well, I think that's a concern. So initially it was sort of opened up broadly. And the concern is, as this evolves and as this moves forward, what is going to happen? I know discussions around it. I think that there are huge opportunities, and really I see a great imperative for the payers to continue to support telepsychiatry, behavioral health in the way that has allowed us to get to this point. I don't understand what would prevent them from continuing, except an intentional decision to try and restrict access. And that would be a financial decision. So if we want to say what is going to be in the best interest of serving population health, what is going to be in the best interest of addressing behavioral health needs, the integration with behavioral health and physical health, to help our population get on the other side of this horrendous crisis that we've all been living through. The documentation of the success of virtual care and behavioral health is clear. The documentation of the enormous prevalence increase and the devastation we're seeing broadly is clear. There is no question about that. So it really is going to be, in my mind. The payers, I hope, will continue to support, and I hope they will continue to have parity that will allow us to deliver care in the way that will allow us to address the mental health needs moving forward. If that decision is not supported, I would see it as egregious. I would see it as immoral, frankly, and grossly unethical in addressing the public health crisis we face as a nation.
Thank you, Dr. Meltzer-Brody. So one of the kind of topics that has come up across all of you is kind of substance abuse challenges as we think about COVID, certainly continuation of some of the things we saw around the opioid epidemic that we continue to deal with. And so kind of curious, what you all have seen in terms of actions to try to help address some of these challenges as we think about the kind of mental health, behavioral health difficulties. I'm not sure who is best to take this one first. So take a volunteer. Danger.
I can go first. I see Hemi's like reaching out for it. So I would say virtual care has definitely helped continue care for those with substance use disorders. We partner very closely with Eleanor Health, for example. That's a provider that does all services for those that have, mild to complex substance use disorder. So instead of sending somebody to an daily outpatient intensive program, they actually do all of those services in the clinic, and they have been very successful in doing urine tests and getting results virtually from the patients, and their no-show rates have decreased to a prior speaker's point in terms of just transportation issues, et cetera. We have received feedback from our members in that, moving into the future, they would like a mixture of in-person and virtual services to be provided, not to be 100% virtual. But I think that has made a huge difference, in addition to the Ryan-Haight Act being lifted and the substance use disorder providers being able to actually prescribe medication virtually without having to see that particular patient first.
I'm happy to chime in next. I agree with all of that. The other thing to think about is opioid settlement dollars. So each state's going to get opioid settlement dollars, and think about how to invest that into the system. So, I think with every, all the projects that we did on opioid use disorder when I was at the National Governors Association, it was like top priority for many, many years. It was all about what is the sustainability of the system? How can we finance it effectively to make sure that we have the networks that we need? And so it's not just, 1 year, 2 year grant, like longer term sustainability to make sure that people are going to have access to those services. And I think that's true in North Carolina, like in many other states. For some states, with Medicaid expansion, they've been able to do more, frankly, just because they've been able to build up networks and people have more coverage. And I think the providers have come because Medicaid is a sustainable financing mechanism, unlike, grants. But that said, I think states have also been creative and thought about, okay, if we don't have that, how do we really build up the network? And I think the telehealth piece has been, critically important for North Carolina, but it's still not reaching everybody, right? Like I mentioned before, the rural areas are still really in need, and so are those people who are uninsured. So I think more progress is needed. I think on the integration side, North Carolina has made great strides to try to integrate, your longstanding sort of behavioral health coverage versus physical health coverage. And I think that is going on a good path. But I think there's still this question about making sure that you have continued networks, which hopefully telehealth will continue to support that, but also how do you pay for it? So whether it's coverage and other means. So I'll leave it at that.
And I'll be happy to, in terms of looking at some of the questions, academic medical centers, how do you see these, addressing this? I think we have an obligation. So I can tell you at UNC Health, I'm, employed by the University and the School of Medicine, but work within UNC Health. We are working very hard on a, strategic plan for behavioral health to address the entire healthcare system, which UNC Health is very large across the state, partnering with others to harness what we've learned and where we can go next. So I would say, yes, I think academic medical centers have an obligation to be full participants, including all the specialty-based care. So there's general mental health, bread and butter mental health, but we also have the specialty care That's really critical in specific areas, and having the ability for people to access that as well. So we are all in. This is a huge focus of what we're planning on doing next. Again, I can't reiterate enough, this relies on our wonderful partnerships with all constituents, including payers. And so that was the piece that wasn't in place prior to the pandemic. That is the piece that's in place now. And our ability to move forward and continue to be successful relies on that ongoing partnership and commitment to serving in this way, while we also then continue to battle all the things. That in and of itself is not going to be enough to declare victory, but it's going to be absolutely critical and part of basic infrastructure to continue to move the bar forward. Otherwise, I can tell you, we will just have people continuing to back up in emergency departments, and we will continue to see just worsening mental health and then subsequent physical health in ways that will be really horrible.
Great. Dr. Kapp?
Yeah, so I just wanted to follow up on some of the comments from Samantha that, before the pandemic, Blue Cross of North Carolina was covering telehealth for mental health services and behavioral health services, so substance use disorders and mental health services at parity. And the pandemic really, I think, just brought to light all of the other payers that were, paying at parity for a temporary period of time, et cetera. So maybe folks were just more aware of this, but I just wanted to clarify that was already in place before the pandemic started. And as we're looking into the future, how do we look at virtual care long-term? Obviously, we have to be conscientious about the total cost of care impacts and how do we promote value. And so looking past into the data from during the pandemic time period is really going to be super informative for us in developing this permanent policy. And from our perspective, as we look at the data, we look at a couple of things, right? Are members using the services, and are they coming back to continue to use the services? Because that's a sign that members are feeling that service is of good quality for them. And then our providers in those particular specialties also leveraging and utilizing those services, since we are paying at parity for everyone at the moment. And what we have found is that the vast majority of all virtual care utilization has been in either primary care or behavioral health. So we know that both members and providers in those two areas are definitely leveraging those services. And we're just continuing to do some, deep analysis in terms of fraud, waste, and abuse, which sometimes unfortunately happens. But just given those findings, there's a good likelihood that the future looks good for behavioral health and primary care and virtual care.
Thank you, Dr. Kapp. And I think it's certainly, as we look at the broader story here, appreciating that access by itself doesn't solve the problem. At the same time, I think as Amy was pointing out earlier, if we don't have access to the system, then, we kind of limit our ability to address the challenge here. And, Dr. Meltzer-Brody highlighting that we've had kind of a wonderful, experiment, from a data standpoint, a horrible experiment from a lived experience standpoint, and that we have a chance to really understand then the impact of that. And put together the pieces in a way that shows some learning from it, right? That we know a lot more than we did a year ago about what works, and again, some things that don't, as we try to think about this. Amy, I'm curious, this question, whether you might be the right person, although we could throw it to anybody. Are you aware of funding or grant opportunities that might enable infrastructure kind of efforts kind of on this telehealth side?
So, from a federal perspective, the Biden-Harris administration wants to reinvest in two agencies that I think are going to be important: SAMHSA, the Substance Abuse Mental Health Services Agency at the federal level, as well as HRSA, Health Resources Services Administration, which is really the organization, federal agency that oversees primary care. And so I am hoping with those investments, if they actually come to pass, there will be more grant opportunities and funding for state and local providers to help with that network and infrastructure. I think we'll just have to see how it all plays out. But I know there's a sincere interest at the federal level to really invest, understanding that we need a better workforce across the country on this. I think the other piece that we're hearing from other states, and it'll be interesting to see, and it was Dr. Kapp, it was really good to hear your comments on the out-of-state provider question. So across the states, with respect to workforce and investment in workforce. I think there's some states I've talked to that said, we're never going to have enough mental health providers in our state in certain locations. We can't recruit. They're just not going to come. We have to rely on telehealth and even, folks outside of our state because we're, a frontier state. We just don't have that many people. I think Dr. Kapp, to your, points about, understanding about, fraud and abuse and making sure everything is done in the way that it should be. I think it'll be interesting to see how this experiment continues and whether that out-of-state workforce is really going to be the supplement that, North Carolina needs. I think every state is different and has different dynamics. So that I think will be interesting. I think at the federal level, the new administration is really interested in understanding this and understanding how they can, build sort of more continuity through programs like Medicaid and Medicare and where they have big levers to pull. So it'll be interesting how it all comes together in the future. Thanks.
Fantastic. Well, I see we are at time now, so let me thank each of you for joining us as we've had a chance to talk about kind of the massive challenges, but also I think the significant progress that's being made, and at least for me, the hope that we can continue to better integrate behavioral health services with kind of our overall approach to well-being. So thank you all very much. I appreciate it.
Thank you very much.
Fantastic. So we will make the transition now to our third and final panel of the day. And during this panel, we get to build very much on the themes that we've already talked about today, but thinking about kind of how do we improve access to primary care for all North Carolinians, and thinking, the shift of value that has been a discussion all along, right? How does that impact primary care, as well as the very real challenges of providing access in rural areas of the state? And so to help us in this discussion, we have three fantastic panelists. We have first Dr. Crystal Wiley-Sine, Associate Professor at the UNC School of Medicine, our System Executive and Director for Health Equity at UNC Health, and Director of the Program on Health Disparities at the UNC Shep Center. We have Dr. Leslie McKinney, Lead Medical Director for Advanced Primary Care and Provider Engagement at Blue Cross of North Carolina, and Dr. Devduta Sanghvi, Vice President of Population Health Management at Duke University Health System, as well as Professor of Health Family Medicine in Pediatrics and Psychiatry at the Duke School of Medicine, and a core faculty member at Duke Margolis. So clearly an all-star group to bring us home today. So thank all three of you for being with us. To start the session off, let's see, I'll maybe call on Crystal first, if that's okay. Could you kind of help us get a lay of the land? How do we think about North Carolinians' access to primary care?
Yeah, thank you so much for having me. And this is a topic obviously very near and dear to my heart as a primary care doctor. So I will say that I think that our access to primary care in North Carolina is not great. And I would definitely love for us to have better access to primary care. We know how important it is as sort of the foundation of the healthcare system. And it's certainly one of the, 21 health indicators for a healthy North Carolina for 2030. And it's vitally important to the work that I also do around health equity and making sure that we have an adequate and well-trained primary care workforce is really critical to being able to provide care to the most vulnerable of our populations. And so I think that, we certainly have a lot to do to be able to better provide primary care in North Carolina.
Great, thanks. Dev, what might you add to help us kind of get a view of the landscape?
Sure, happy to add, and thank you, Brad, and thank you to the Keenan Flagler School for the opportunity to participate in this panel. I completely agree with Crystal. There's insufficient primary care. We wanted to get a little bit more granular. You can say that depends on where you live in the state and really what your insurance status is. And I think we heard some of that in the conversations around behavioral health and so forth. And I don't think we can understate the importance of trust with the system. And I think that really gets to some of the points that Crystal was trying to make, that from an equity perspective, it's not just the numbers that matter. Is that capacity really the kind of capacity we need? And I think we've learned for a long time, just because you have insurance doesn't necessarily mean you need access. So we should be careful to not confuse someone having insurance of any kind with some level of access to healthcare services, including primary care.
I will just add also to that, I think the North Carolina Institute of Medicine, I think the targets were really that there would be one primary care provider for every 1,500 people. And at least the data as of earlier in 2020, maybe around March or so, the beginning of the pandemic, we were, out of our 100 counties, only 60% of them actually met that target. And there were, probably 7 of our counties then who were substantially below that target. So I definitely think that, we have a problem in terms of access. And as Dev was saying, I think, again, insurance is one indicator, but having a regular source of care and someone that you identify as your primary care provider, are other ways besides insurance status to think about access. And I think that there are lots of people who would not say that they have a regular primary care provider or a regular source of care. And that's troubling, because some of those people may actually have insurance. So the onus is on us to then, think about what can we do to engage them and to bring them into our systems and make sure that we're adequately caring for them.
It's a great point that, as you're both highlighting, just because someone has insurance doesn't mean they truly have access. Of course, we know that part of the barriers is some people don't have insurance. So for some, those can be a negating impact. I'm curious to hear, maybe Leslie, we could start with you. What are some of the primary reasons that you see that are really leading to these access difficulties? Sorry, I think, Leslie, you're still muted.
Whoops. Is that better?
Perfect. Yes.
Okay. Sorry about that. When we look at our network, and thanks for having me, across the state, it's interesting to see that still about 50% of primary care is provided by independent primary care across the state. But if you look at the East and the West, in other words, more rural areas, it jumps 60, 70%. So I think you're hearing a familiar theme. In the urban areas, it's pretty good access. But when you get to the rural parts of the state, it's just a different story. And I think you're like, why is that? And I think it's multifactorial personally, just having lived in North Carolina my whole life. But part of it is there's just a shortage of primary care providers, whether that's physicians or PAs or FNPs, we just have a shortage. And then you think about, well, where do folks want to live, and how do we get folks into the more rural parts of the state? And so I just think it's a lack of opportunity sort of for people to grow their families when you start looking at everything around, even for a physician that has a family and those things. So I think it's supply. I think it's getting folks out there, it's education. But I think those are the biggies. And then access for people, we've heard a lot about social determinants of health today. We all know transportation, food, hearing it over and over again, broadband. Yeah, telehealth's great, but if you live in rural Eastern North Carolina, good luck. So we've got just these real North Carolina urban rural is one of the things that I've become more tuned into just work recently. But Dev, Crystal, love to hear from you.
Yeah, I was just going to say, I think just what you said, Leslie, and the closure of many rural hospitals does not help at all either. So, I mean, I think you're right. The urban rural disparities in access are really very stark. And again, compounded by the fact that I think it compounds the situation and has certainly downstream health consequences of rural hospitals closing at the rate in which they have.
Deb, you want to add into this one?
No, I don't know how much more to add other than to say ditto and ditto. I think that the point that Leslie made about independent primary care and how critical it is to so much of our state is an important one. I think we should also stress the quality of care that many of those providers are able to deliver. It is high quality care comparable to anywhere else that you see. So this idea that somehow there's a quality issue in any way associated with the rural-urban divide, I don't think that's necessarily a fair comparison. Because what we see in terms of quality, and Leslie, you might see this through some of the data you have at Blue Cross, there's no difference in quality. In some cases, the quality may actually be better in some of these rural areas just because of the comprehensiveness of care that many of these providers provide.
Yeah, and just
and so
probably highlight.
Yeah, please.
I was just going to sort of, the other thing that all of us know, but I just think it's important to say, and you've seen this in COVID, is oftentimes the independent primary care practices, these are community leaders. These are the public health folks. I mean, these folks are invested in their communities in a way that's wonderful, and their patients trust them. And there's just something so important about that I just think for North Carolina and the fabric and how we talk, it's just really important to always remember that.
Yeah, it's a great point. And I think, as we look at this challenge, certainly as I think about, North Carolina is representative of the broader U.S. struggle for some of these urban and rural elements and kind of other things that we'll talk about here. And so it's part of the excitement that there's so much innovation going on here, because I think there's a chance then that we can take that and share it more broadly, but it certainly highlights the urgency. And so Leslie, I'd love to hear a little bit about what you're doing at Blue Cross as you think about this access challenge and supporting the state.
Yeah, I'd love to share some of what we're doing. It's been really exciting work. I feel honored to participate. So one of the areas when we think about the independent physicians, and this year has been a great example. Again, you hear from us, we're lucky. We still have 50% independent physicians. Is, with COVID in the spring, we were seeing significant impacts. We all now, are well aware, fee for service, oh my goodness. So the independent practices, which are small businesses, were really struggling, honestly, to survive. And we knew how critical they were. So, really thanks to really wonderful leadership at Blue Cross, we launched a program called Accelerate to Value that was really geared at quickly getting direct financial support to the independent practices. And, so proud of the work we did and the folks we work with. And we were able to sort of help 513 independent practices across the state. We funded about a little over $19 million to these practices to really just directly support them through what we knew was a difficult time. And we also asked them as a part of that to join us in our work in the value space in a program called Blue Premier, which is an accountable care organization sort of model. I believe, and I think we're seeing that it's very supportive of the independent physicians. So we are excited to work with more. So that's one thing, support directly the independent physicians. And then two, work with them more closely in our Blue Premier accountable care organization. We're working with a partner, Alidate, in this space. We're also working with CCPN or CCNC, the folks may know, a really wonderful North Carolina organization. And now we've got over 500 primary care practices in the independent ACOs. So we're working with them around quality. We're working with them around population health and affordability. And we're working more closely with them. So a lot of work there. And that really helps with the rural. When you look at the independents, again, that's helping us really support the rural space. So we're doing that. We're working with the large health systems and all of their employed primary care physicians. They have lots of great work going on with the health systems as well related to primary care. So we've got most of the major health systems in our Blue Premier programs. Some of those also work with independents like UNC Health Alliance and Cone Triad Health Network, WKCC. So that's going well. And then finally, we're looking to sort of do some work with folks that we're partnering with outside of the state. We're working with a great provider group in Eastern North Carolina, Galileo, that's really helped us sort of say, we've got a problem in the East. What can we do? So we've been working closely with them in the Medicare Advantage population, doing some really good work. They use, sort of a primary care practice surrounded by more virtual care. They have a mobile van. So we're really working to try to reach more of our members in that way. So really sort of independence, work with health systems, and then again, do we need to bring in some other care delivery models to help us address certain population needs and gaps? So at a high level, that's how I would describe it.
That's helpful. Thanks. And so maybe we'll start with Dev, but I'm curious to hear from both Dev and Crystal, kind of what programs you see, whether it's within kind of your larger health systems or just in the state more generally, also trying to address this kind of primary care access challenge for kind of the rural parts of the state.
Yeah, if you look at one of the approaches is to understand why providers enjoy working in rural settings. And there are good data that outline that it has to do with the lifestyle, a deep commitment to the community, in some cases, special incentives, in other cases, the opportunity to be that independent business person that we had just talked about. So I think you have to first understand, we need to first understand what's the incentive or what attracts providers to those areas. And then really being able to develop programs that capitalize on that. And I think there are incentive programs that have shown some benefit. One that immediately comes to mind is the Medical Society's Community Practitioner Program that identifies individuals, not just physicians, nurse practitioners, physician assistants, and others who really want to commit to underserved areas, provides opportunities to develop leadership skills, to be that community leader that Leslie mentioned, and also financial incentive to offset loans and those sorts of things. So those are the types of programs that really work. We just need more of them. They're expensive, and they're getting increasingly more expensive when dollars are becoming increasingly more challenged. So I think trying to incentivize purely on money is going to be increasingly challenging, but it can be done, as we've seen and there are probably many other examples of similar successful programs today.
Yeah,
Great.
I would say, I think one of the, areas of greatest potential, which we've seen really blossom since the pandemic started, was telehealth. And I think that we're not going to go back to, medicine as per usual prior to March of 2020. So I think really thinking more intentionally about how to expand our telehealth offerings and to make them so that they are relevant and able to be implementable in rural and underserved communities and with marginalized and minoritized populations and individuals. So I'm really excited about the opportunity to think creatively about how to expand telehealth. I think it's gonna, there are certainly some guidelines we have in the literature, some work that's been done in California at UCSF by some colleagues to think about telehealth for equity and what are the considerations for health equity as we expand telehealth. So I think that there are some great opportunities there. I also think thinking creatively about, where and how we deliver healthcare. So thinking about linking health centers with schools and taking more of a, how do we leverage and link to other things that are existing in the communities and really be able to have more of an integration between the social and the sort of medical drivers of health. So I'm excited about that possibility as well. And to hear Leslie talk about Eastern North Carolina and all the challenges there is so, it's both bitter and sweet. I'm from Eastern North Carolina. I grew up in Sneaksbury, which is in Onslow County. So I'm definitely fond of the East, but lots of challenges. So I do think, when we kind of design new systems or think about how to augment our current systems, really designing at the margins and thinking about what really is needed to capture those who are most vulnerable and design with them in mind, because I think we'll get everybody else if we do that. But if we're designing and thinking about what's going to work for the folks who are kind of in the middle, then we'll miss the people who are at the margins. So I'm excited about the potential to do things differently.
No, and I think it's a great point as you're highlighting, that we have, we have a great infrastructure, but we know it's not enough. And so we see kind of telehealth has been a way of expanding that. Of course, telehealth has its own challenges to make sure that both on the provider side, folks are set up and, on the person side. But then, we know we still need to go further still. And as you're tying in there, thinking about kind of points of access within the community that maybe haven't been the traditional ones, but in some ways going back to the roots of medicine, that used to be in the community, kind of came out and going back in some ways when we see the themes. I'm curious to hear from y'all how, and this has been a theme throughout, but sort of how COVID has maybe changed thinking, changed kind of the urgency of some of this. And so maybe Leslie, we could start with you on that one.
Sure, and I think this sort of ties, the one concept here for me, I certainly want to hear from Crystal and Deb, is the other thing that's important is supporting primary care providers in the current model. Fee-for-service it's going to kill them, quite frankly. It's, can I see 30 people a day? My overhead in my practice is 60%. It's not sustainable. So when many of us are thinking about sort of value-based models that are very primary care centric, it's really the concept of a team. So it's a physician, it's APPs, it's health coaches, it's behavioral health, it's an integrated model, it's virtual, but it's the team, so that the lifestyle and the way that folks want to take care of their patients can be more fun again. We can sort of move a little bit away from the hamster wheel, what I call a hamster wheel mentality, and more to sort of getting us back to taking care of people in a way that seems wonderful and more rewarding. So, and I think COVID really highlighted that, because, here, the only way I'm going to support my practice is to see 30 people a day, and oh my goodness, they're all at home. So I think for many of us, it just sort of really crystallized the importance of thinking about how we honestly pay for primary care. Again, I've been really focused on this anyway. So I think it sort of opened the door to say, hey, maybe we need to think about this differently and more deliberately. Is there a better way to think about some sort of PCP capitation payment or something that begins to reward the really care of a primary care's patients panel? And so I would say for us that virtual care, no brainer here. I think, we all knew it, and now voila, it's here. So I think virtual care is here to stay. And, for me, the other thing that's just been amazing to watch is how practices have adapted so quickly under stress. Pediatricians giving vaccines in their parking lot and, dividing their waiting rooms, and just, it's been so wonderful to see people respond so quickly to take care of their patients. So, and for us, that's what it's all about, is access and helping us take care of folks. So, for me, virtual care, pay differently, and then innovation.
I think those are great examples, and certainly, never bet against kind of the ability of the American medical system to respond to a crisis, and we've seen that, right? I think now it's can we take some of these lessons and use them more forward thinking, so that we're not in a crisis, and hopefully address some of these real challenges that we've been highlighting. Deb, Crystal, kind of comments on COVID.
I think for me, the biggest things that COVID has exposed to the world, certainly many of us were not surprised, were the inequities and how striking they are and have been. But I think it's really shed a light on that for many people who weren't necessarily thinking about that before, and how we have to be intentional about addressing those social contextual factors that influence health. So as an example, one of the biggest things that's happened with COVID is just the amount of social isolation that it has caused. In my other hat as a researcher, as a health services researcher for the past 15 years, that's one of the areas that I focus on in my research. And it was one of those things that, well, people didn't talk too much about it before, but then as we got into COVID and the whole social distancing and the impacts on people's mental health and, just the loneliness, the isolation, all of those things that have gone on with the pandemic, there's been this renewed interest in, wow, what are the, there must be health implications for this. And we've known for 40 years that social isolation is one of the strongest drivers of mortality. It's on par with smoking and lack of physical activity. Most people wouldn't know that. The Institute of Medicine, the National Academy of Medicine, recommended back in 2014 that health systems, for example, take an assessment of social isolation as one of the many social determinants of health that should be incorporated and integrated into electronic health records. But not many places outside of some community health center networks have done that systematically. And behold, we realize like that is critically important. I mean, whether or not people have people in their networks, who can they leverage to help them manage their health, who can they go to for lots of different reasons. So one of the things that we did as an example is we started using medical students to call our most vulnerable patients. I mean, this was totally driven by COVID. They weren't having classes, and we said we gave them, in my practice, we gave them a list of our patients that if there was somebody you were really worried about, older people living alone, in the midst of a pandemic, call them. They started calling them, finding out what their social needs were, and just calling them each week. And I cannot tell you how much of a benefit that was to our patients, just somebody checking in, knowing that someone cared. And so again, I'll wrap this up by just saying, I think for me, COVID has shown us once again the vital importance of addressing these non-medical social drivers of health that quite frankly account for more of the variability in health status than anything that we do actually as care providers. So that's what it's shown me, is that we have to come up with new ways or leverage things that we know work from the scientific literature. We have to start implementing those things in practice.
Yeah, Brad, I would just add on top of all of what's been said is that I think COVID has also taught us how fragile some things are in our broader healthcare enterprise. It's also told us where we do things really well when it comes to collaborating, whether it's traditional medical providers with our public health infrastructure. And it's also taught us that we can do better. And so to the extent that we have been able to solve these problems, each one of them should really be a learning opportunity to say, how can we do things better? Where do we need to invest? What do we need to really focus on? And I think in many ways that gets to some of these ideas of as things have changed in the political landscape, what that might mean in terms of where we focus and how we're able to really move forward while learning at the same time.
Yeah, and Dev, to follow up on that, I'm curious your thoughts on kind of the change in administration, how it may impact these things we've been discussing around access in primary care.
Yeah, that's a great question. I think there's optimism that the mandate for health insurance might become something that gets significant time and really making health insurance an option for anybody who lives in this nation. And I know we talked earlier that insurance doesn't equal access, but it's a good step. I think other things that we're hearing that are promising are how to make pharmaceuticals more affordable. It's a tough question to ask. We know that there are issues with R&D and everything else that sometimes compel drugs to be expensive, but a thorough look at why and how we can use maybe some business principles when looking at pharmaceutical prices, particularly in Medicare. And then finally, I think Crystal kind of alluded to this, giving science and evidence the opportunity to really help drive some of the decision making that we need to make. So I think that there's quite a bit of optimism as we think about not only COVID, but all the things that we're going to learn as a result of what we were doing through the COVID crisis.
That's great. Leslie, would you add anything on kind of thoughts of changes you think we'll see or maybe hope to see?
Yeah, I'm aligning with Dev and things I've heard from others. I mean, I think we know support for ACA to go Obamacare. I mean, that seems likely. Support for Medicaid, wonderful. And then, I'm also personally sort of curious to see what we do with CMMI and all the work that's already started related to sort of value-based care. Where will they go with that? But yeah, I'm certainly optimistic, and now we're sort of waiting for the details. Sounds like tomorrow's going to be maybe a big day.
Big day tomorrow.
Even extending or opening, having additional open enrollment for Obamacare that's big. So
Sure.
I'm excited to hear more.
Absolutely. So I know we're coming to the close. Would love to kind of give each of you a chance to offer a concluding remark, thinking about kind of where we're headed. And so maybe we'll go Crystal and then Dev and then Leslie, and then I'll wrap us up. Crystal?
This has been really great. So thank you again for allowing us the opportunity to talk about this. I'm just optimistic. I think that I guess if I had to summarize, I will summarize with a quote from Reverend Martin Luther King Jr. You know, the moral arc of the universe is long, but it bends towards justice. And I think that that is true for health and health policy as well. So I'm just hopeful that the changes will be positive and that we'll continue to care for all of our population well.
Great, thanks, Jeff.
I would absolutely agree. And I think one of the real opportunities we have in North Carolina is our collaborative spirit. I mean, you have Duke, UNC, and Blue Cross on the same call, and all we've been doing is nodding at what each and every one is saying. And I think if there's any evidence that we're going to be able to do it in North Carolina, it's what we've seen here. But that extends in a number of things you've done. You've seen collaboration in everything in understanding the COVID crisis to the way we're collaborating with the vaccine. And the state's been a great partner in all of that as well. So I'm really optimistic for how North Carolina can use its infrastructure, its assets to really solve what needs to be solved.
Great, thanks. Leslie?
Yeah, Deb, you're sort of reading my mind when you sort of are here looking at us, and I'll say for me personally, this is a great moment. And I think many of us knew it's getting the right leaders together. We're going to be much stronger. And I think we're making real progress. And again, kudos to Dr. Mandy Cohen and her team at the state. I think that's been another really wonderful example of leadership. But we can do a lot together, and we are. So, you know, it's easy to focus on what we don't have. But I honestly think we're making progress, and I think we'll take, you know, all the challenges from COVID and turn this into something better. So, you know, who thought we'd be on a call where we were really all talking about social determinants of health and doing something about it? Blue Cross is giving food to people. I mean, these are really amazing times. So thanks to everybody for all your work.
Absolutely.
And thanks for having me.
Yeah, of course. Thank you, Crystal. Thank you, Leslie. Thank you, Dev. Appreciate you being here today. On behalf of the Center for the Business of Health here at UNC, Blue Cross of North Carolina, the Duke Margolis Center for Health Policy, I'd like to thank all of you for tuning in today as we thought about kind of the future picture of healthcare under the Biden administration. This event has been recorded. We'll make it available to anyone who may have missed a session or would like to share it with your networks. So thanks, everybody. Stay safe.